So I will be presenting the demographic profile of bivalent patients and patients receiving rabies post-exposure prophylaxis in Puerto Rico. And this is data from 2005 to 2008. We unfortunately do not have all the information available to do a rapid assessment at this point in time for the latest years. So just to give you a little bit of background, about rabies in Puerto Rico, we received over 6,000 animal bite reports that are investigated annually for possible rabies exposure. Approximately anywhere from 600 to 800 patients are then referred to PEP after risk assessment. This usually runs around $2 million in PEP costs alone. This does not include any costs associated with man-hours or with vaccination requirements, hiring of providers for vaccination. In Puerto Rico, the small Asian mongoose is the main reservoir for rabies and has been recognized as such for some time now. Over 60% of all PEP referrals are due to companion animal exposure. No companion animal registration or mandatory rabies vaccination is in place at this point in time in the island, and less than 20% of companion animals are thought to be vaccinated against rabies. As far as how the information flows for our surveillance system for suspect rabies exposure, what you can see is that we receive information through medical providers who are obligated by law to report potentially exposed individuals through bite wounds or exposure to saliva from wounds or mucous membranes. That information then reaches the Environmental Health Division and the Epidemiology Division at the Department of Health. Suspect cases, animal cases, if they are captured, and we can place them in isolation or observation for 10 days, we'd like to do so, and if no change is consistent with rabies infection are noticed, then no further action takes place. If we are able to capture the animal, then we place the animal under observation. If behavior changes are observed or are present at the time of capture, that animal is humanely euthanized and samples are sent to the state laboratory. If the state laboratory confirms that it's a positive rabies case, then PEP is immediately initiated. Those cases where we are unable to capture the animal, then we immediately conduct risk assessment, and depending on the evaluation, cases are referred or not for PEP. So the objectives for this presentation is to basically describe the demographic profile of bite injury victims and PEP case patients in Puerto Rico during fiscal years 2005-2008, and to identify and describe animal data associated with post-exposure prophylaxis in the island. Also, we would like to take the opportunity to disseminate and share the findings with the different stakeholders. Very important for us is to raise awareness among all healthcare providers, and this symposium certainly has given us the opportunity to do just that. We would also like to tailor animal bite and rabies prevention education efforts and aim animal rabies immunization campaigns and animal control efforts into municipalities that have high animal bite injury rates and PEP rates. Additionally, we would like to, with this information, be able to draft public health policy and legislation and regulations pertaining to rabies prevention and control. So we will present the data in terms of time, place, and person. So let's look first at the concept of time. When are these bite reports being reported? And this data is only those cases that have been actually investigated by the Epidemiology and Research Office. It does not take into account all bite reports that are received by the PRDOH, as that would involve a very high number of records to be examined, and at this point in time that was not possible. So what you can see here, this is on your horizontal axis, you have the month of exposure. On your vertical axis, you have your number of cases. And the 3 fiscal years are represented by 3 different lines. The blue line is 2005-2006, the pink line 2006-2007, and the green line 2007-2008. And what's important to notice here is that around February, we tend to see an increase in the number of bite reports that are, bite injury reports that are reported to the PRDOH, and that more or less extends all the way out to June. And this is a little bit different from the data that Jesse presented, which, where you can see very clearly in the United States, in the mainland United States, that bite reports are largest or greatest during the summer months. Here we start in the spring. We don't necessarily have a clear explanation for that, but that is something that we would like to investigate. When we look then at the PEP referrals, again with the same scheme with month of exposure on your horizontal line, number of cases on your vertical line, and the same differentiation of fiscal year by color, we tend to see it's the same pattern. Again, the months of February, we tend to see an increase in the number of PEP cases that are referred, and again, that is consistent with what we see with the bite injury reports. When we look at distribution of where these animal bite injuries and PEP cases are taking place, we can observe that those areas that are deepest in blue color intensity are representing the areas where we tend to see the highest rates. So as color intensity increases, PEP bite injury rates also increases. And you can see these rates are by 10,000 population, not by 100,000, because it makes more sense to have it represented true to what municipality average population is like. So we can see that we have anywhere from 4.6 bites per 10,000 population, all the way to 6.2 bites per 10,000 population. Again, bite injuries tend to concentrate in large urban metropolitan areas, and few municipalities in the central mountainous regions have consistently high bite injury rates. When we do the same exercise for PEP rates, we can see that PEP rates per 10,000 population range from 1.9 to 2.31. Again, coastal municipalities, except along the northern coast of the island, tend to have elevated rates, and few municipalities in the central mountainous regions have high PEP rates consistently throughout the 3 years that we examined. Puerto Rico is divided into 8 different health regions, and we wanted to understand what was the burden of case investigations per health region. And there were some very interesting findings. Again, bite injury rates, stratified by fiscal year, gave us that the highest burden, case investigation burden was highest for San Juan, Bayamon, and Fajardo, which are really high, densely populated metropolitan areas. Doing the same exercise for PEP rates, we noticed that those municipalities, or those regions that have municipalities with large rural components, were the ones with the highest burden for PEP. Again, Mayagüez, Ponce, and Fajardo. And when we look at data for 2010 for animal positive animal rabies cases, we can see that this is consistent. The laboratory so far this year in 2011 has determined that there have been 36 positive animal cases, and those have been mostly on the region of Mayagüez, Caguas, Arecibo, Bayamon, and Ponce, which are again the health regions that are mentioned here. As far as person, it should not be surprising that males are a little bit more adventurous, and they tend to be the ones that have the highest rates for all bite injuries and for PEP referrals. And as far as age, we also find that the median age for all bite injuries was 25 years old. The median age for all PEP referrals was approximately 30 years old. However, when we look at rates, not just at averages or numbers, when we look at rates, the individuals that are less than 15 years old represent the highest rates for both variables or outcomes of interest, which are bite injuries and PEP referrals. So So it's important to understand that those little kids are the ones that are at highest risk for bite injuries and PEP referrals. And that's not that different from what we see in the United States. As far as body area affected, again, the extremities appear to be those most affected, and it should not be surprising as you reach out to touch an animal or as you're walking by and an animal bites you on the leg. The important point that we should make here is that exposure without a bite represents about 4.2% of all cases that are referred for PEP. And that's important to understand because sometimes if there is not a bite wound per se, a lot of clinicians or even a lot of environmental health investigators do not want to or do not consider that there has been an exposure. They truly do not understand that exposure of saliva on an open wound or through mucous membrane constitutes an exposure. When we look at the different animal species implicated in bite injuries and PEP referrals, again, we tend to see what's true for the rest of the world, except in the United States, that canines and felines represent or companion animals represent the largest number of bite wound exposures. Also in Puerto Rico, it represents the highest numbers for post-exposure prophylaxis. And we believe that that has to do a lot with the fact that there is no mandatory rabies vaccination in the island. Since we don't have clear and complete histories, we go ahead during our risk evaluation and we recommend vaccination of those animals that we cannot document rabies vaccination. Interesting to see is that although mongoose represent only an average of 4.5% of all cases during the time period for the study, it does represent close to 12% of all cases that are referred for PEP. When we looked at the rabies vaccination status of animals implicated in exposures, potential exposures, we can see that most of the bite injuries are inflicted by own animals. And again, this is not different from the epidemiology observed in the United States and most of the developed countries. However, only 36% of those animals were reported as vaccinated against rabies. 91% of canines were not vaccinated, 17% of felines were not vaccinated, and only 1% of equines actually were vaccinated. 91% of canines were vaccinated, 17% of felines were vaccinated, and 1% of equines. Among PEP referrals, and this should make sense, exposed by owned animals, only 1.2 were vaccinated against rabies. Again, if it's an owned animal, and we can observe the animal, and the animal after 10 days observation just has not developed any signs of rabies, then we do not need to proceed with PEP treatment. However, in those animals that we cannot trace back or that the owner disposed of the animal because precisely of the bite injury, where we cannot document vaccination, then those are referred for PEP. Let's take a brief look at mongoose bite injuries by municipality where the bite occurs for this same time period. Again, with increased intensity and color, you can see increased number of bite reports. And you can see that municipalities in the coastal areas have the higher numbers of mongoose bite reports. And interesting or important to signal out is the Yucca tropical forest area that encompasses about 8 municipalities. And although the number of cases per in the region per se, we did not pull it out and highlight it out as such, it represents about 15 bite case reports in the last during this time period. locals are not the only ones that get bitten by dogs or mongoose, and Puerto Rico has a strong tourism industry, and our travelers and visitors are at risk for being exposed to rabies, be it by stray animals at the beach or in certain areas, and certainly by mongoose, particularly when they go to certain tourist attractions like the Yunga tropical forest. And during this time period, fiscal years 2005-2008, there were 37 reports of individuals, non-residents of Puerto Rico, that had to be referred for PEP after exposure or after a bite from a dog or from cats or mongoose. And again, the region of Fajardo, which encompasses most of the municipalities in the tropical rainforest area, they saw about 15. They saw 15 of all those 37 cases. For us locals, it's important to understand insurance coverage among PEP cases. And again, unlike what Jesse presented earlier, where 80% of cases are managed at the private level, 61.5% of all cases in Puerto Rico are reforma patients or government-based insurance coverage. Also, Medicaid represent 26.3% of all cases. And again, we need to understand that because these individuals are usually the ones that have less access to services, and we need to pay close attention to make sure that they indeed can access prophylaxis treatment after exposure. Rabies exposure case reports or investigation, which also acts as an investigation form, it's really important for us. At the present time, we do not have an electronic reporting system for rabies or for many of our other reportable diseases. And it is important for providers to really take a close look at the investigation form and fill out the form as best possible. The data recovered not only includes information from the patient, but it also recovers date and address, physical address of where the exposure occurs, so we can track down and make appropriate interventions and prevention activities. It also recovers the circumstances under which the bite was produced. Was this a provoked bite? Was there an animal with puppies? Was it an animal with that was eating, or did you invade the animal's territory? And all these are important elements to understand and be able to look at when you're doing your risk assessment. Also, animal species is important. If we receive an animal bite case report by a green iguana, we immediately know that does not represent a rabies exposure case. Description of the wound and description of the type of exposure. Was it saliva through open wound or mucous membrane? Was it a deep wound? What part of the body? All those are important elements that should be documented on this case investigation form. Also, what treatment was initiated, if anything, and the healthcare facility and the provider that took care of that patient, so we can follow up. And as you can see, this case investigation form, which is a real case, it's half of the information is missing. So this presents serious challenges at the time when we need to undertake our risk assessment. So as with any study, there were limitations to the study and how we looked at this data. These results are not representative, like I mentioned at the beginning, of all bite injury case patients, because being paper-based, it was very difficult to look at over 6,000 paper-based reports for all injuries per year. So we limited our study to those that were actually investigated by the epi office. Again, animal bite reports, as you see, are handwritten and are paper-based, and reports may be subject to reporting or misclassification bias. Again, we we were looking at this data hindsight 2020, and so it's difficult sometimes to really understand how they classified initially those cases. Additional variables of interest that we believe would be interested were not available or were incomplete, such as the severity of lesions. We do not currently have a score to allow us to classify the different lesions. We were not able either to follow workdays lost by the patient, nor type of insurance coverage was always available on the record. And data from PEP referral to treatment initiation and completion is not always present. And I think that's very important, as in past years, through the collaboration with CDC, Dr. Kiss Robertson took a look at precisely that, and she discovered that there's about a 20-30 day delay from PEP, from receiving the bite report to PEP initiation, and we need to improve that. And again, data was grouped and analyzed by fiscal year rather than calendar year, which sometimes makes it a little bit difficult to look at and interpret the data. So in conclusion, bite injuries in PEP case patients in Puerto Rico are mostly males, on an average of 30 years. Injuries occur mostly during February and June. There are high animal bite rates in PRDO, Puerto Rico Department of Health regions with large metro urban areas, but the highest PEP rates occur in regions with greater rural areas. The hands and legs, the extremities, are the body areas more commonly injured, and those individuals less than 15 years old represent the highest rates for both outcomes of interest. There is 54% of all bite injuries and 20% of all PEP referrals are inflicted by animals of known ownership. However, only 36% of owned animals are vaccinated against rabies. And animal bites do represent greater than 90% of the mode of exposure among PEP referrals. There are several recommendations that came out of this study, and definitely to deliver animal bite and prevention messaging was a very important one. Messaging should include responsible dog ownership, what to do, procedures after an animal bite, and supervision of human-animal interactions, especially when we're talking about little kids. That's really important for us. Modernized reporting modality and data management and data sharing, that's top priority on our list. And also to share the findings with the different stakeholders so that we can assist in tailoring bite prevention education and intervention projects. The expansion of the study period for further analyses, we think it's also very important. So what have we have done? Well, this is a draft of a potential rabies exposure and PEP reporting through electronic methods. So that briefly, the healthcare providers will enter data directly into a website, and that will be received by the PRDOH server, Department of Public Health server. Immediately, that server will put out notices to the regional epidemiologists, the environmental health lab, or inspectors, and PEP providers if it's a mongoose case. Mongoose cases, mongoose exposures or bat exposures are immediately vaccinated without necessarily going through a risk evaluation or risk assessment. So they would be immediately referred to the provider for vaccination services. Also, we would coordinate with the rabies lab to undertake rabies testing if a sample is available. And again, Central Epi will receive all that information in order to provide better guidance and analyze the data. Also, as far as educational interventions, we have been very active with the World Rabies Day organization in producing some information materials. And this year, through collaboration with the World Rabies Day and the Global Alliance for Rabies Control, we were able to put out this poster that highlights the importance of the mongoose as a rabies reservoir, because we have noticed that there is a lot of misconception and misinformation among the general public. So I would like to acknowledge the following individuals for their contributions during the time period of the study, and if you have any questions, I'll be happy to entertain those. Thank you. Jesse?
This is just a reminder for the online audience. Please type any questions you may have into your chat window for Jesse or for Brenda.
I have a question for Jesse. I enjoyed your both presentations, and Jesse, since I know the data from Puerto Rico, I'm trying to do a comparison here. Since all of the vaccines that we provide in Puerto Rico are bought by the Puerto Rico Department of Health, and we basically give the vaccination to all people that are exposed, those 800 a year or whatever. And you were saying that in the mainland, 70 to 80% are done by the private sector, which is quite contrasting. We're looking to see the pros and the cons of changing to the private sector doing the vaccination. Do you recommend that? Do you think that's a problem? What problems do you have in data collection there that we're able to get much easier here? How does it work in benefit of the patient?
Sure, and just to briefly restate for those on the webinar, the question was in regards to the differences between the administration in Puerto Rico, between private and public sectors in Puerto Rico versus what we saw in our survey. So one clarification is that that 80% was 80% of the jurisdiction, so it's a little bit more difficult to get what actual percentage of patients are. Sorry, it's the survey that we conducted were of jurisdictions, so state and city health departments. So that was 80% of those indicated that the majority of their patients are receiving PEP through a private hospital or clinic. It's more difficult to get the detailed information of how many individual patients that represents. From our perspective, there are certainly advantages and disadvantages to the private sector. An obvious advantage is increased access at multiple clinics. That has been seen in the past, but of course there are questions about that as well, especially when we saw situations like the supply limitation where we found that even in the private sector, because of access to biologics during that time period, it was very centralized at emergency departments. The difficulty, of course, is that you tend to lose the epidemiological information of post-exposure prophylaxis. And under the right situations where you can institute reporting, I think that information can still be collected even from private hospitals. The difficulty, of course, becomes then the manpower that you have to put into epidemiologists to continue to monitor that data that's received. And even in states where there is a requirement to report those cases, some previous studies have found that by and large they're only receiving about 50 to 60% reporting of post-exposure prophylaxis from hospitals in states where even in states where it is mandatory to report that information.
Our fear is that we get 25 bites a day and we're able to clean out 23 and vaccinate 2. So we vaccinate 10% of those that get exposed. And we fear that if we give this to the private sector, it will go up to a much higher rate. Has that been the experience in the mainland?
Yeah, so again, just to repeat, the question is if moving away from public sector involvement and exposure assessment, would you see increases in post-exposure prophylaxis because there's not an exposure assessment? And that is the finding. Historically, looking back at some papers going from the 1980s forward, in states where they did begin to move from direct supervision from public health departments, they typically found a 4 to 6 fold increase in post-exposure prophylaxis where there wasn't direct involvement of state health officials or local health department officials.
And as Dr. Guillen has mentioned, it's very time-consuming, and our epi nurses devote approximately 90% of their time to doing risk assessments. So it is indeed quite a burden. But again, when you take into account what's at stake, I think it's personally it's time well spent. But we need to find healthier solutions to that.
And yet at the same time, historically in the mainland as well as here in Puerto Rico, it demonstrates that risk assessment by knowledgeable public health individuals has a significant reduction in post-exposure prophylaxis that otherwise wouldn't be needed. This is one of the reasons why when we have these limitations in supply that Jesse mentioned, our single biggest strategy is that public health risk assessment, which served us well during our 2007-2009 period when we saved the country from going into a supply shortage on the basis of the risk assessments that by and large were a historical asset because of nerve tissue-based vaccine, which makes one wonder if what we see in Puerto Rico is a legacy that never changed into the private sector, which was really the biggest strategy why it went to the private sector and no longer into the public health one, because of the adverse event ratios associated with nerve tissue-based vaccine. It was an evolution that still has served you well, and yet from the standpoint of the U.S. nationals, it creates other problems for us, i.e. it's much easier to write a script than it is to do a risk assessment. And it was one of the largest singest complaints we had from the medical providers during our limitations in supply, that when medical providers become used to writing a script and doing things with a status quo, they do not appreciate the imposition of public health consultations into that process to do the right thing.
And it also, I think it opens up legal questions as far as, you know, they are the clinicians, they are the providers, and it is their understanding that they want to refer that patient for PEP. And here we are saying, no, we did risk assessment and we understand that the risk is really low and this is unnecessary use of the vaccine. So it is a gray zone, and I don't know how to best address that.
And you're exactly right. That was the biggest single complaint, was the legal medical of how can public health insert itself this when it's a patient, physician, individual decision. The rationale, both from the national, state, local, was because we know from the epidemiology that the majority of these are inappropriate, as the data has shown. And from a public health standpoint, it was more critical to necessitate that the patient that was actually exposed would have those critical biologicals available in a limitation that without that risk assessment would otherwise have been lost.
And for us,
Very interesting situation.
It's really important understanding, again, that most of the patients that are bitten and are referred for treatment are those that have limited access to health care. So we need to safeguard that, or ensure that those individuals do have access to the medication when they need it.
And I know during that limitation in supply, it created severe problems for you here, which is one of the reasons why we had that engagement and why we're back here now with Puerto Rico as the host of the region.
That's right.
The crisis.
Yes, I have a concern.
Take a question.
The Puerto Rico system of reporting bites. I think that the system is deficient. It's not working appropriately because maybe not all pediatricians, general practice, doctors, even local hospitals and area hospitals are reporting to the health department the bites, and the bite reporting system doesn't work. It doesn't start the system to investigate. So I think that it's worth putting vaccines in Dr. Hans to have to improve the system of reporting.
Thank you. And the comment that was posted, yes, the comment that's posted on the floor is that there are deficiencies in the Puerto Rico reporting system for bite injuries, and we are well aware of that. And we are working, trying to improve both our reporting system and also in educating and raising awareness among all healthcare providers, because it is important for them to understand. We have had providers that have said, oh, there is no rabies in Puerto Rico. We're fortunate that we don't have human cases of rabies, and we have had only, I believe it's 2 reports in the last 50 years of human mortality.
Yes,
but that doesn't mean that we don't have rabies, and you're absolutely right.
That is what happened. Precisely that the people think that there is no problem here in Puerto Rico. It is. I know one of those 2 cases, and I know 1 case. And in this particular case, he went to a private doctor, he went to a local hospital, and he went to an area hospital, and nobody reports that bite.
Yeah, the red flag, as you said.
Nobody. No doctor reported that bite to the health department. department, and one of those cases, the person died.
Right, and again, on the floor, the concern is that in 2003 actually was that case. There was an incident where an individual was bitten by a stray dog, and the individual sought medical assistance at least in 2 different occasions, and the red flag of rabies exposure was never raised. And as a consequence, that was our last human case fatality reported in the island in 2003.
And even that maybe more cases are happening, but they just go by maybe people are dying, and maybe the diagnosis is viral encephalitis or something like that. But if you don't investigate very well, there may be more cases of rabies.
It's always possible that some encephalitis cases might go under the radar, definitely.
But when we had the West Nile surveillance system, we looked for that and we couldn't find them. So again, yes, there might be a possibility, but it's not that obvious. We've looked, and at least for West Nile, we looked very closely and couldn't find it.
And again, on the floor, there's a comment that Dr. Ruyan, who's the state epi, mentions that during the West Nile virus surveillance, we actively look for near-invasive cases of West Nile, which can be, on occasion, confused, and we were not able to, looking through West Nile, we were not able to document rabies cases either. So
a follow-up question to this ongoing discussion. Given that no system is ideal, and given that we all admit there can always be cases, we know this occurs on the mainland and not detected. Do you have any ideas why you think we've been fortunate in not having human cases, given the high animal bite incidence and given the relatively high incidence of prophylaxis? Do you think there's any special qualities operative in Puerto Rico to help explain why luckily we've been fortunate in having a low burden of cases?
So the loaded question that Dr. Ruprecht put forward is whether we have any idea or an opinion as to why we have been fortunate enough that despite our deficiencies in reporting and acquiring the information for bite exposures, we have not seen human deaths. And I think that I wish I had a clear explanation, but I think that those with the exception, of course, in 2003, again, there's a lot of bites occurring, but again, not all should be considered a risk for rabies exposure. And again, it is consistent with other data that we have seen that most bites occur by owned animals, and those are, on average, mostly kept indoors, so risk is low for spillover rabies from mongoose, except in those rural areas where dogs are allowed to roam a little bit more freely. And I think that there are certain pocket areas where we know we have mongoose spillover rabies, and those areas, I think, have greater awareness, and that might be why in those areas they do get reported, and we are able to actually take care of those patients. That would be my only possible explanation right out of the top of my head.
Question for Jesse. With the mainland, you see a lot of course, we're seeing cats becoming the most common companion animal with human exposure. Is that thought to possibly be a relationship between low vaccination coverage or actual reservoir and companion animal interactions, where you might have cats being in more situations where they're going to come in contact with raccoons or skunks versus the typical situation with the dogs?
So just to recap the question again, being on the mainland, similar that we see cats as being most frequently reported rabid animals involved in potential human rabies exposures, is that involved with the interaction with reservoirs, the function of their vaccination level. I think it's really a situation of both. There certainly are focuses. We know that cats overall have much lower vaccination rates, and there are also focuses in states in the Mid-Atlantic, like Pennsylvania and Virginia, that have the majority of reported mortality cats. And so in these areas, there's certainly suggestions that low vaccination rates have an impact, but also because we know there's a considerable more spillover from raccoons to non-reservoir animals compared to other reservoirs like skunks and foxes. That these kind of coming together in a perfect storm may be one of the explanations why we're seeing those focuses.
Yeah, I don't know the code.
Peter, is there any questions online?
I have a question.
Oh, sure.
Has there been any effort into creating, or is there a legislation project to make obligatory the rabies vaccine here in Puerto Rico?
Thank you for that question. And the question is whether there is any legislation that has been proposed for mandatory rabies vaccination at the island of companion animals, or even registration of companion animals. And the answer is yes. For more than 10 years, the Department of Health and the Puerto Rico Medical Association, Veterinary Medical Association, well, in Spanish we call the Colegio de Médicos Veterinarios de Puerto Rico, has put forth legislation trying to address those very same issues. However, legislation has always been, ironically enough, stopped by animal groups, because they understand they don't see it as a public health measure, and they see it just as a way of perhaps veterinarians acquiring more money, which is not the vision of the Colegio or the Department of Health. But yes, indeed, legislation has been put forth, but we have been unsuccessful in achieving that goal. Yes.
A few requests from the authorities, because I think that we don't need legislation for the registered animals. What we need is to collect those abandoned animals or wild animals. That is the problem. The people who has animals, they have very well care and everything. The main problem is those wild abandoned animals. I can go anywhere on the streets, and there are plenty of dogs killed on the streets, and it's a real problem.
Yeah, the issue that has been brought forth by the floor is that the animal control it should be the way to go. And again, it has been difficult for more than 10 years. All these animal groups and the Colegio, the VMA, has put a lot of effort into trying to control stray animal populations, and it has been an uphill battle, and we have not been successful at achieving those goals. This is not a one-pronged approach; it's a multi-pronged approach, and for that we need serious educational efforts toward responsible ownership. And this is not a problem that's just of Puerto Rico. We tend to see stray animal populations in the rest of the Caribbean. Again, and in Puerto Rico and, for example, in the Philippines, they have what they call a lot of community-owned dogs. The dog does not belong to one person in the community, it belongs to everybody, and everybody feeds the dog or the cat. And when animal control services go around to try to pick up these animals, they hide them. So it's really, really difficult. And again, I don't know if it's an issue in Hispanic countries, but spay and neutering of our animals, people don't look at it as a method of animal control, unfortunately.
Here is the same.
They don't embrace it.
The animal doesn't have owners. When he attacks you, but when you defend yourself and attack the animal.
Definitely, if the animal bites, like you just said, if the animal bites somebody, oh, it's not my dog. But if the animal is just hanging out, it's everybody's dog and everybody feeds it. I certainly agree with that. And again, that is the phenomena of what it's called community-owned dogs. And actually in the Philippines, there's very interesting data looking at that, where when they removed the companion animal populations from these communities, you had new individuals that came in that were not linked to the community, and the number of bite reports increased, and the number of PEP, potential rabies exposures, increased because they were animals that were new to the community. So maybe it's not just an issue of removing those animals, but making sure that those animals are indeed vaccinated, and that the community does embrace the idea of rabies vaccination and spay and neuter. Although that might not directly reduce animal bite injuries, but it at least might reduce the number of animals that keeps adding on to the community, and the number of PEPs that are associated with those bites. Dr. Rivera.
Richard Franca asked me to ask Jesse Blanton, why did you differentiate on your slides by species numbers over time, skunk rabies virus variants as opposed to the other carnivores?
So the question was in regard to one of my slides showing the frequency of reported wildlife species over time, and the fact that the line for skunks was differentiated between skunk variants and raccoons variants. So this has really kind of become a function of the increase in raccoon rabies in the United States, and was really there to illustrate the important role that raccoon rabies is not just rabies in raccoons, it's a variant that with broad spillover into other species. And that while skunks used to be the primary species with a few different rabies virus variants, increasingly more skunks acquire rabies from interaction with raccoons than they are actually getting it from another skunk.
And is that a rational, reasonable concern from an epidemiological prevention control aspect?
It is in regards to maintaining, because of the recognition that there's considerable spillover from raccoons, it makes them a very critical species in regards to trying to prevent the spread of raccoon rabies throughout the rest of the United States. Given that raccoons are broadly distributed, but where they are the reservoir for rabies is very restricted to just the eastern states, and this is why the oral rabies vaccination effort in the United States maintains an effort to prevent the westward progression of the raccoon rabies virus variant.
So as a follow-up, with more than 100 million doses of vaccines spent on oral vaccination on the mainland, as a follow-up question for Dr. Rivera, what does she see in regards to, do you believe that rabies could be eliminated from Puerto Rico?
Thank you for that question, Dr. Rivera. And the question is whether we believe that through oral vaccination, perhaps we can eliminate rabies from Puerto Rico. And I would like to think so, and I would like to hope so. There is, from our discussions this week and previous weekends, we understand that there is hope for a vaccine, oral vaccine for mongoose, and we would like to incorporate that into our rabies prevention program in attempts to reduce mongoose exposures among our population, both human and animal. Also, combining this product with animal control, with reproductive control, would be very beneficial, particularly in those pocket areas that we tend to see increased mongoose attacks.
Would you foresee anybody in Puerto Rico who would be upset? In essence, if one could come up with a future not only oral vaccine to control the disease, but in theory, a safe and effective enough contraceptive that would drive fecundity approaching zero, would you foresee any problems, issues from an environmental, ethical, philosophical problem with people who would have concerns from the actual elimination of the mongoose from Puerto Rico?
Well, I don't know if we'll be able to eliminate mongoose because, as we have seen in other jurisdictions such as Grenada, it has been very difficult, and they're a smaller island. So I don't know that we will be able to totally eliminate the mongoose.
Would there be concerns about that?
Right, and I am certain that there will be individuals that will be concerned and perhaps opposed to elimination of mongoose from the island. However, we must remember that, just like Jesse pointed out, mongoose was an introduced species, and it has created havoc among our natural flora and fauna. And one of the main reasons for the low numbers of the Puerto Rican parrot, the Amazona habitata habitata, and why it's on the endangered list, it's because of predation of chicks and eggs by mongoose. So there's a lot that we could probably benefit from elimination of mongoose. However, we have, like we start messing up with the ecology and biology, we need to consider what possible scenarios might ensue when we eliminate, and if we eliminate mongoose. So again, it's a blessing, but it might bring other issues. It has to be done very thought out process. Dr. Rivera.
Well, following on that line of thought, the fact that we're spending over $2 million a year on vaccination that could be spent in more efficient public health programs for the rabies prevention program, how would you spend those $2 million if we had our vaccination that was effective in Puerto Rico?
And thank you for the question. And Dr. Young asked, how would we probably how can we envision better spending those $2 million that are currently spent on vaccination of biologics for PEP into other components of a rabies program? And I wish I had a across the board straight answer, but it's difficult. We certainly have to invest in a mongoose oral vaccination and contraception model, but I don't think that we can remove any of that money at this present time from the, or divert any of that money at the present time, because we do need still to cover those individuals that that require PEP. So we need to find a little bit better solution, and perhaps again through registration of and mandatory rabies, we can perhaps assign some funding from that to for a rabies oral vaccination in mongoose. So we have to look at innovative ways to fund whatever program or whatever project we initiate, and then perhaps consider diverting some of those $2 million as PEP requirements go down, potentially go down, then divert them to keep funding the project that has allowed that coming down on cost for PEP. Any additional questions or from the webinar? I think everybody went out for lunch.